privilege to welcome you again for the Snippet series. Last month, we had a pathology quiz in our college. So we had conducted pathology snippets in which we covered 7 topics. The way we do snippets is that we first discuss a topic in brief and then discuss its MCQs. So total 2 snippets per topic. That makes it a total of 14 snippets. Coming October, we have also planned anatomy quiz. So therefore, we are starting with anatomy snippets. A brief introduction about myself. I am Dr. Ame Anil Munemane, intern and founder president of BB2MC Quizzing Society. So let's start. So the first topic with which I plan to start the anatomy snippets is brachial plexus injury. One more thing, in these anatomy snippets, we'll all be covering clinical anatomy topics. So the main focus will be on the disease. However, we'll also be telling you in brief about the anatomy of that part, organ, or that system, but that would be brief. The main focus would be on the disease, the etiopathogenesis in short, clinical features and treatment. So starting with the anatomy snippet series with brachial plexus injury. So brachial plexus consists of roots, trunks, divisions, cords, and branches. And here comes your mnemonic number 1 of the day. I'll not be putting the mnemonics on the slides. If you want, you can note them down or just hear it. So the mnemonic number 1 is, which is given in BD Chaurasia, is the parts of brachial plexus can be remembered by Ramu Taylor drinks cold beer. So it stands for roots, trunk, divisions, cords, and branches. So the brachial plexus is made from anterior primary rami of spinal nerves C5 to C8 and T1. However, occasionally you can have contributions from C4 and T2. If it is C4, it really means before C5. So that is why prefixed brachial plexus, and T2 because it is after T1, post-fixed brachial plexus. So trunk, there are 3 trunks, upper, middle, and lower. In divisions, you have anterior and posterior division from each trunk. Again, cords are also 3 in number, medial, lateral, and posterior. Some of the very easygoing MCQs are that the thickest cord of brachial plexus is the posterior cord, whereas the thickest nerve of brachial plexus is the radial nerve. And radial nerve, by the way, is also the largest nerve of the brachial plexus, covering the entire extent in its root value. So this is a very good image I got from Google. It's actually showing brachial plexus in a form of a tree. And because, branches, trunk, roots, these all are parts of a tree. So they've made this good image in which we can see that the roots are there below from C5 to T1, then trunks, divisions, cords, and last there is branches. And if you zoom the image later, when you're seeing the video, you can see ulnar, median, radial, axillary, and musculocutaneous written over it. Now, injuries to brachial plexus, there are 3 diseases or 3 lesions which can happen. First is the global total brachial plexus birth baby. Global total brachial plexus birth baby is like the most severe type of paralysis in which the entire brachial plexus is affected, and it is very rare. I mean, it's the rarest of the diseases. The etiology of global total brachial plexus baby is same as that of Erb's and Klumpke's paralysis. Now moving on to the second, which is Erb's paralysis. So Erb's paralysis, the site of injury is the upper trunk. This is the diagram that you can see on the left hand side of the screen. What is the cause of injury? So all these brachial plexus injuries now, they happen during difficult prolonged labor. That is what we learn in obstetrics, which is given in DC Datta, that all these injuries happen during prolonged difficult labor, and sometimes there is a presentation of shoulder dystocia in the woman. So shoulder dystocia with prolonged difficult labor, you are likely to suspect brachial plexus injury, and therefore as an obstetrician, when you are delivering this woman, you have to make sure that you are taking care. So there are certain maneuvers in place which are there for shoulder dystocia. like the Zavanelli's maneuver, but I'm not going to go into details of that because that is not the topic. So what can happen is there is undue separation of head from the shoulder. So to understand this point, you have the mechanism of labor. And although it's not the topic of discussion, but I'll still like to tell you that in mechanism of labor, it goes by the mnemonic end diastolic flow, ice red. Okay. So all the cardinal stages of the labor, that is engagement, descent, flexion, internal rotation, crowning, extension, restitution, delivery by extension, and last is delivery of limbs by lateral flexion. So the thing is that it is seen in birth injury, that is difficult childbirth, or there is fall on the shoulder. So the fall on shoulder can be either anteriorly or or posteriorly. Then during anesthesia. So which are the nerve roots which are involved? So as I've talked that Erb's paralysis mainly happens due to injury to the upper trunk. So upper trunk basically constitutes C5 and C6. In Erb's paralysis, it is mainly C5 and partly C6. So the muscles paralyzed are mainly biceps brachii, deltoid, brachialis, and brachioradialis. Partly of the supraspinatus, infraspinatus, and supinator. So biceps here is a flexor as well as a supinator. Deltoid again is an abductor, right? Supraspinatus, infraspinatus, these are parts of rotator cuff muscles. So naturally, it is very logical for us to conclude that if biceps is not working, then maybe flexion and supination is not happening. If deltoid is not working, abduction is not happening. So if abduction is not happening, the arm is in adduction. So the contralateral or the opposite actions are happening, or the limb is in that place. Now I'd like to talk about the diagram. So in the diagram, if you see, there is a Erb's point, which is made as a junction of 6 nerves or 6 nerve root values. The suprascapular nerve, C5, C6, the Erb's point, nerve to subclavius, anterior division, and the posterior division. Right. So as I talked before, that the arm will hang by the side, adducted and medially rotated, whereas the forearm will be extended and pronated because the action of flexion is not happening because brachioradialis is a flexor. So the deformity is called as the policeman's stiff hand or waiter's stiff hand or porter's stiff hand. Before going to Klumpke's paralysis, I would like to discuss the branches of the cords of the brachial plexus in brief for the mnemonic sake. So branches from the lateral cord can be remembered by the mnemonic LML, which is lateral root of median nerve, musculocutaneous nerve, and the lateral pectoral nerve. Then branches from the medial cord can be remembered as M4U, that is medial root of median nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial pectoral nerve, and ulnar nerve. Lastly, the branches of the posterior cord can be remembered by ultra, upper subscapular nerve, lower subscapular nerve, thoracodorsal nerve or nerve to latissimus dorsi, radial nerve, and axillary nerve. So the policeman tip hand or the waiter tip hand is Erb's paralysis, Erb's point formed by the junction of the 6 nerves, mainly by C5, partly by C6, difficult prolonged labor, shoulder dystocia. These are important points of Erb's paralysis. So you can see this. These movements are lost, what are there on the slide. But there's no point again discussing because we have discussed the contralateral lesion, which is there. So this is the Erb's paralysis diagram on the left side. Moving on to Klumpke's paralysis. So if Erb's paralysis was involving the upper trunk, Klumpke's paralysis is involving the lower trunk. And the cause of Klumpke's paralysis is overstretching of arm or undue abduction, like too much of abduction or clutching something with hands after a fall, sometimes birth injury. This is a very trick question, which I saw in some USMLE questions, mainly from birth injury, Erb's paralysis results. Klumpke's is rare with birth injury. So if in the clinical vignette you see birth injury, always think of Erb's paralysis first and Klumpke's paralysis later. So the nerve roots involved here are C8 and T1, but mainly T1 and partly C8. The muscles paralyzed are the intrinsic muscles of hand, T1, the ulnar flexors of the wrist and the fingers. So what happens because of that deformity? It leads to claw hand, and there is unopposed action of the flexors and extensors, mainly of the fingers. So on the left side, you are seeing the two diagrams, which is complete claw hand and ptosis. Ptosis is a component of Horner's syndrome. Essentially, ptosis means drooping of the eyelid. So Horner syndrome is that proximal to the white ramus. There is 5 things in Horner syndrome: ptosis, meiosis. Meiosis is constriction of pupil, anhidrosis, that is decreased sweating, enophthalmos, that is opposite of exophthalmos. Exophthalmos is protruding eyeball, enophthalmos is eyeball going in, and loss of ciliospinal reflex. And if the clumcase paralysis remains untreated for a long time, or if it goes into a severe form, there are some vasomotor changes, because not just the motor components, we all know that a nerve can also innervate a sensory area of the skin, and that is why even sensory losses can happen. So the long-standing case of paralysis can lead to a dry, scaly skin. Nails can crack easily with atrophy of the pulp of fingers. So this is winging of scapula. The third disease, that is injury to long thoracic nerve. Now, long thoracic nerve root value is important to remember: C5, C6, C7. It is also called as nerve to serratus anterior because it supplies that muscle, or nerve of Bell. Okay, serratus anterior is also called as boxer's muscle. So if you are preparing for any quiz, you should know these alternate names. So what can be the cause of injury to long thoracic nerve? Sudden pressure on the shoulder from above. If you are carrying heavy loads, and not just heavy loads, heavy unaccustomed loads, like if a laborer is tomorrow carrying heavy loads, or a coolie is carrying heavy loads, he is accustomed to it, so he knows the proper way in which it is to be holded. But people like you and me who are not used to carrying heavy loads, if we suddenly start doing that, there is a chance that some damage can occur. And what happens due to this is there is winging of scapula that you can see on the left hand side. So what happens is that there is an excessive prominence of the medial border of scapula. So sometimes they can give you winging of scapula, sometimes they can give you excessive prominence of medial border of scapula, or in the question sometimes it can be written excessive prominence near the inferior angle of scapula. So by the way, inferior angle of scapula is also an important landmark because it constitutes a vertebral level. So what happens because of that? See, serratus anterior will not be able to function. What is the function of serratus anterior? Overhead abduction. So if I'm talking about abduction, because the topic has come, so initiator of abduction is supraspinatus. That is 0 to 15 degrees of abduction is done by supraspinatus. 15 to 90 degree of abduction is done by deltoid, and later overhead abduction and above 90-degree abduction is done by serratus anterior. So you won't be able to raise your hands above your head. You won't be able to do this if your serratus anterior muscle is paralyzed. Apart from that, you won't be able to push. So this is a very common clinical vignette, that there is loss of pushing and punching actions. So that is lost. But the thing is, what we should be understanding, because we are going deeper in the topic, is that overhead abduction is only partly affected, because overhead abduction is not just done by serratus anterior, right? So it is only partly affected, but there is complete or let is significant loss of pushing and punching. So this marks the end of snippet 1. I hope you have liked the video. If you have liked the video, please like, share, subscribe the video. And if you have any suggestions or if you have any comments, please mail us on our Quizzing Society email ID, which is bvdmcquizingsociety@gmail.com. I'll be seeing you again for the MCQ discussion of brachial plexus injury. Thank you.